welcome. My name is Mitch Sanders. I'm chair of the Communications Committee for the Wound Healing Society. It's my pleasure to offer another fireside chat with just a wonderful author. Today we have Dr. Matthew Regulski from the Wound Institute of Ocean County, and also you're a fellow faculty of the Royal College of Physicians at the University of Scotland, which is quite an honor as well.
Sure. Thank you very much. Appreciate it.
You're welcome. So just to have you know, I love energy-based devices and perfusion devices, and so I've been kind of following this field for some time. And before we get started, can you talk a little bit, and I wanted to mention that the paper is entitled Impact of Repeated Remote Ischemic Conditioning on Diabetic Foot Ulcers, a Proof of Concept Study. So anyway, it's something near and dear to my heart. I really love this topic. Could you talk a little bit about RI?
See,
RI
tongue twister.
Yeah, it is a tongue twister, and the biochemistry behind how wounds heal with this device.
Well, you know, there is still some unknowns about how this machine is actually working. There have been some elucidation on that it activates a neuronal pathway, a humoral pathway, and increasing in ATP. I think that, as you are aware, when we have ischemia that it's going on, causing a multitude of factors, as we see in our diabetic patients, but people in general that have cardiovascular disease, there's a lot of things that are occurring in the cellular milieu. You get a lot of inflammation, cellular swelling, the acidosis that occurs when you get mitochondrial swelling, efflux of cytochrome C, and activation of these effector capsases, proapoptotic factors, and proapoptosis. So we get a lot of generation itself of reactive oxygen species, right? When xanthine oxidase is increased as well, and that increases that reducing endogenous antioxidant factors. Leukocyte adhesion factors are upregulated, ATP goes down, and a lot of hypoxanthine as well, creating that milieu and activating the inflammasome activation, atherosclerosis. So we think, and upon that reperfusion of that limb, and it's happened to a couple of my patients as well, upon reperfusion, there's also that paradox. There's a pH paradox, there's a calcium paradox. We have increased lactic acid that's occurring down distal to occlusive sites, leading to glycolysis activated, decrease in the activation of sodium potassium ATPase. You have that ionic homeostasis is disrupted, increase in sodium and calcium, a lot of cellular swelling, activation of proteases, calpains, phospholipase, and then we get into apoptosis of cells. Mitochondrial permeability transition pore gets open, cytochrome C efflux, activation of those capsases, sarcolemmal membrane disruption, and then we're into apoptosis. So we think what is going on in there, even though we're going to do some more molecular studies out at the University of Iowa so we can elucidate these factors, VEGF, stabilization, HIF-1 alpha, stromal-derived factors being activated, a multitude of interleukins that are being released as well, that we're activating anti-inflammatory pathways. We're increasing ATP because oxidative phosphorylation gets decreased upon ischemia. And even, like we said, in that reperfusion injury, we're washing all those bad factors out. They're coming back into the circulation. And I've had people that have had angioplasty in the hospital, bad diabetic foot ulcers, as we always have our vascular people come to see them because we need to optimize flow. It's just good standard of care. I've had 2 people have massive heart attacks post angioplasty that I believe it's from that reperfusion injury because we're washing all that garbage out. That's getting into the circulation and causing those problems as that paradox does. So we think that we are increasing and activating anti-inflammatory factors, revving up endogenous antioxidant systems, and we're reducing that inflammation. The ischemia itself triggers the body to think that we have an occluded artery. This is a wonderful cuff just going over your arm. It calculates your blood pressure probably about 20 times a minute. It's really incredibly software. And it goes up about 20 to 30 millimeters of mercury above what your systolic is. And it's up for 5 minutes, down for 5 minutes, up for 5 minutes, down for 5 minutes. A 45-minute cycle, easy to do. You're sitting on your couch, watching TV. You're relaxed. You're at home. You don't have to travel somewhere, go to a doctor's office, do those things. And so what we're thinking is activation of anti-inflammatory pathways, a neuronal activation, a humoral pathway, increasing ATP. But of course, we want to do those studies and look at those factors that are being elucidated as well, because I, as a clinician, really want to know what's occurring on that molecular pathway. That's what we think is going on.
Right. So just so you know, I'm a molecular biologist, biochemist by trade, and we do a lot of qPCR in our lab, looking at up and down regulation, genes, and microRNA, and so on. What I do want to say for the viewers out there that are just trying to understand on a cellular level, so you have this kind of compressive force that's ongoing when you have this cuff on, and what's that's doing is it's stimulating the neurons in your muscles to then release factors, either signals back to other neurons, back up to your brain, and then back down to where the wound is. But it could also be releasing factors into the bloodstream as well. Right. And so we're talking about nitric oxide. We could be talking about microRNAs, or even stromal derived factor 1 alpha. It could be a variety of things that could be going on. There's a lot of parallel, obviously, in learning from what people have used this before for heart attacks, for how this could be working on chronic wounds. Right.
And I think, when we looked at those studies beforehand, for instance, the Israeli study, they did 1 pump in 3 weeks and wanted to see how their outcomes. But when you have a chronic wound, there's so many factors that are going on. It's incredibly hypoxic, tremendous inflammation, cellular senescence that's going on. We thought that we should definitely be using this more obviously than that. So we started with the 3-day-a-week interval. I really think that, and we had great results with our study for that. Doing good standard of care, sharp debridement, moist wound balance, offloading, managing biofilm and inflammation in there. And we had pretty darn good results on people that were severe vasculopaths. We did ABIs, PVRs, and toe brachial indices before and then after a 12-week interval, just to see, could it influence that? Could it make that better? So we think that those factors are being activated, but at the same time, tricking your body into thinking, oh, we have this occlusion. We need to make factors to break down the inflammation, perhaps to make new factors to also have some collateral circulation formation that occurs when you have an occluded artery. And those are the things that obviously we're going to be testing in the labs.
So let's talk about some of the clinical results in terms of percent area reduction in wounds, week 12 and week 20.
Right. It was interesting. Now, we wrote a protocol, because in randomized controlled trials that they're usually real optimized patients. Are they real world patients? And that was one of the things that I really wanted to see. People that had lower ABIs than normally you would do at a diabetic ulcer. People that are on dialysis, right? They're excluded usually in clinical trial stuff. Wounds that are deeper than just subcutaneous tissue. No active infections, obviously. No bone sticking out and pussy drainages and things of that nature. But I wanted to do people that had higher A1Cs, for instance, that are excluded from trials, because those are the people that we are seeing every day. All right, real world patients. We have a lot of dialysis patients, a lot of people with A1Cs between 9s and 10s and 11s, actually. People with ABIs of 0.5 and toe pressures down around 0.5 when they should be about 0.7. So we did people that had significant disease that would be dispatched from doing normal randomized controlled trials, because I know some people confuse that and they think that these are well-optimized patients. They're going to do pretty good. So we wanted to use patients that are excluded, because that's what we're seeing every day. And those percent area reductions that you see in the paper were very significant at the time. Even at the 20-week mark of those people that were there, we had that did not heal, we still had a 54% the area reduction on those very hard to heal patients, severe vasculopaths. There were some people that are inframalleolar disease below the ankle out into the foot, where nothing but collateral circulation, did not have a named vessel going out there. So we took a lot of patients that would be excluded from randomized controlled trials, because those are the people that we are seeing every day. And I wanted to see, can we have an impact, or does this not work for that everyday difficult dialysis, diabetic, higher sugar patients with very difficult wounds to heal, significant vasculopaths? Could we have an effect? Could we do something upon it? Or are we just wasting time? So
So the standard of care is typically what, 25-30% will heal on their own.
Yeah, right. Oh, David, the great dermatologist from Penn. Oh my gosh, his name escapes me right now. He was in 1999. He did some studies showing that at 12 weeks with moist wound balance, sharp debridement, and the offloading was just a surgical shoe. He had about a 21% healing rate at 12 weeks, and then when you went out to 20 weeks was maybe 25%. So yes, that's how it normally is if you're just doing those things. Now, obviously, I always like to use a total contact cast, and I had some of those patients that were in a TCC. I think that's really the gold standard, as a tremendous healing rate by itself. It's the best offloading device. And if we couldn't, then we use a diabetic cam walker or surgical shoe too, because some of these patients, it was their driving foot. They couldn't be properly offloaded. So yes, you are correct that those healing rates with just standard of care, 20 to 25%, not great.
Right, and so the healing rates for life cuff are what, 54% at 12 weeks?
Well,
and
that was a percentage reduction. 20, yeah, it was upwards of at that 20-week interval, we had 83%.
Yeah, that's pretty far out though. So
right.
So, and one other question that I had is, for patients that have diabetic neuropathy, you wouldn't think this device would work. So did you exclude those patients or no?
I did not exclude those patients. Neuropathy is a very difficult entity to treat. It's a metabolic and it's a vascular problem as well. Vasonivororum gets occluded, and the metabolic perturbations that are occurring, the aldose reductase pathway, the hexosamine pathway, the pentophosphate pathway, all those leading to disruption of myelin sheath. Very difficult to heal. And we did take tuning forks and we did some Weinstein on people before and at the end of their treatment. And we're going to tally that as well. But I just wanted to see, could it improve some of the neuropathy? Could it not? People that had painful neuropathy, allodynia, paresthesia, dysesthesia, some people noticed that they were able to feel, patient-wise, feel farther distances down their legs. They felt like diabetic neuropathy is a stocking and glove distribution, toes to knee, fingertips to elbow. I had patients that said when I would percuss them or on the common perineal nerve, use a tuning fork to touch, that they could feel farther down their leg doing the life cuff. Now, life cuff is supposedly on a molecular level is equal to 30 minutes of exercise. So if these people are getting a molecular workout, perhaps we are helping some of that blood flow into the nerve. And I'm just going by what the patients were saying, what they were feeling. I told them not to expect miracles when we do this. This is not going to be this thing and you're going to feel great. Your wounds are going to heal. Your blood flow is going to, your neuropathy is going to go away. We just want to see what happens when we try this. So don't expect miracles. But at the same time, there were some patients that did have better alleviation of some of their symptoms of neuropathy.
But my only point is, if you excluded the patients that had severe diabetic neuropathy, you probably would have had better results.
Probably, but
because you're not getting those signals back to the neurons. Then you're not, how are you going to be able to deliver this? The neurons are already damaged and already compromised.
Right. And probably,
so that's my only question.
Probably, but you know what? I wanted to do people that had aggressive problems, that had pretty significant disease, because I don't want to exclude them, because they're get excluded in RCT, but I'm seeing them every day in the office, in the clinic, in the hospital, and we're trying to treat these people and alleviate their symptoms. So I really went to these hard patients to see if we could have some kind of effect, or are we just wasting our time? Yes, and you're probably right. Neuropathy is very difficult to treat, can have significant effect upon wound healing. Nerves play a great part in the wound healing cascade. But I wanted to see, could we have an effect on flow? Could we heal? But perhaps with the neuropathy, I'd love to do a study on neuropathy. Perhaps we have to do this every day and do it out longer to see if we can have effect. I don't know, but I would like to do that for our next trial.
Okay. So there was an earlier paper that did study our RIC, and you said the results were not as impressive. Is because the life cuff has had a better modality of more pulses, or
I think because we used it more often. All right. in the trial, we did it 3 days a week. That Israeli trial that had the once, they used it once in 3 weeks and still had a 44%, I think, healing rate on that. But I think hopefully my goal is that for patients in the future that have this, to use it every day. And it's a 40-minute treatment. Do it in the comfort of your home, so the compliance we know is going to be good. And I would also like to see those people using it on other modalities. I think perhaps I have an inflammatory spondyloarthropathy I was diagnosed with, fortunately, in September. And I've been using the Life Cuff, and I use it twice a day. I use it in the morning, and I do it once in the evening. And my SED rate and CRPs have been steadily coming down, and I don't feel as achy. I have some kind of atypical inflammatory spondyloarthropathy. My rheumatologist feels it could have been because I had COVID way back when in February 2020. He thinks it could have come from that. But my SR and CRP have steadily been coming down, and I don't feel the achiness as much since I've been using that. So that's just anecdotally from me. So I'm wondering if that's because of the anti-inflammatory effects that it can have.
So the great news about this product's relatively easy to use, and many of the patients got to use it at home for the latter parts of the
Correct.
trials. Now, there were some, I don't know if I'd call them side effects, but there were some patients that did have some discomfort from the treatments. Can you describe that a little bit?
Well, most of it was from the arm pain of inflating the cuff. Because it's got a cycle. It's that first inflation. It goes up probably to about 190 to 200. There's a fail-safe mechanism on there that if it does go above 250, that it will automatically shut off. So most of their complaints was that. One of their complaints, one patient had his arm had a bluish discoloration after he got done with the cuff, and it lasted probably about 5 or 10 minutes after he got done with his last cycle on it. But then it did return, which was interesting to see. Most of it was just from the cuff pain, because you do, as you're inflating, you want to be able to sit still. We have them sit in a chair or lie down on the couch, keep their arm down at their side, not to be moving around, not to really be talking, and doing it that way. But that really was only the side effects that I experienced from patients. We had a nurse would go out, sit with them through their treatments, and just in case if they had problems or anything of that. But obviously in the future, it's going to be designed so that anybody can put it on and use it at home. We're also designing some features into it where you can talk through the device through the physician that's monitoring or the nurse. So you can actually talk real time like a walkie-talkie through it, which I think will be exciting too.
So the results are very encouraging. The pitfalls to this study, obviously it was retrospective data for controls. I guess it was controls that you had before that were standard of care, yes?
Correct.
But the numbers are very reasonable for what is a typical standard of care.
Right.
How do you see designing the next set of trials to get better outcomes or statistical relevance?
I think that perhaps, we use people that have better A1Cs, have better initial Dopplers on them to see how their flow is, better nutrition regimens as well. But again, I really wanted to see, can we have an effect upon the real world patient, the sick patient that we're seeing every day? So obviously we can make more rigorous the inclusion, the exclusion criteria that we use for the protocol to optimize it in that way. But again, I just don't feel that's the real world patient that we're seeing. But obviously, we have to design more rigorous trials.
I think when you're up against cell tissue products that have healing rates that are approaching 90% in 12 weeks, and you look at even negative pressure wound therapy, which is 75, 80%, even some of the new PICO data is higher. You have a kind of a high bar to kind of reach to kind of set some of those levels. Still, for a home use device, you're over 20 weeks, you're getting great healing rates. So,
and it's much cheaper to use too.
Yeah.
And so we imagine the compliance rate will be great. But also I'm thinking too, perhaps, Mitch, if we start using it on patients that are perhaps in the pre-diabetic stage, cardiovascular hypertension, the number one risk factor for a cardiovascular event, perhaps we may be able to use that on patients and head off catastrophic problems I think perhaps that's just something that I've been thinking about and talking with some of our PhD guys about, that if we release these anti-inflammatory factors, if we're releasing antioxidant and upregulating these endogenous antioxidant factors, could we have an effect reducing that inflammation and preventing patients from having catastrophic problems as well?
Or recurrence of VLUs or DFUs.
Right.
Many of these
exactly DFUs have a 50% recurrence in 1 year. But again, chronic ulcerative DFUs, multifactorial problem. Biomechanics are off. They need good molded shoes. I do a lot of surgery to correct those abnormal mechanics, preventing problems from occurring in the future. With injectable fat that we have now to help regenerate the fat pad plantarly as well, because they have tremendous atrophy of that from chronic inflammation. That's been a really good thing from MTF that has done. And being able to put tissue in there, alleviate the pressure, the friction, the shearing. There's a lot of things that can go on. And absolutely, perhaps we can reduce that inflammation and we can make better scarring as well, more pliable, more robust tissue instead of that hard block of scar tissue that you get, perhaps reducing those pressures. It's possible.
Yeah. So one question is this product already out on the market, or is it still waiting for approval? What is the stage?
We have about 1.5 years before we have it out on the market. A couple of software changes to it that we're going to do, things to make it more easy, like the Bluetooth, so you can have a walkie-talkie and be able to, the patient can speak through it, talk to me, or talk to whoever is monitoring them for doing that. We just have a couple of tweaks for that. Probably about 1.5 years we'll have in the market. But of course, we want to do bigger national clinical trials as well to prove its worth.
Just for your own benefit, as I mentioned before, Alira Health does a lot of regulatory work and does a lot of 510K submissions and
Sure.
De novo, what have you. And the simpler, I always like getting a device that's simple, approved first. Right. And then adding the bells and whistles later, because when you start adding all this EMR capabilities to a device, it becomes very complex and harder to manage from the FDA's point of view.
Absolutely.
And right now, I already have a very interesting functional device that could help patients now. So what I recommend is the simpler the better, and the faster to market the better.
Right. Absolutely.
But if we can help you in any way, we'd be delighted. So
we would definitely are going to investigate that pathway, without a doubt.
I did want to put in a plug for SAWC Fall is coming up. So if you're going to be there, I hope to take some people out for dinner. So if you're around, be delighted.
I'm going to be there.
Do you go to Innovations in Wound Healing? It's in December.
The one in Key West?
Yeah.
I have not been there. I would love to go down there. I have friends that live in Marathon, so.
It's highly sponsored by the Wound Healing Society, a lot of Wound Healing Society members. Okay. And I'm planning a fishing trip if you want to go. So keep it in mind.
Tarpon fishing?
I may go bone fishing. It may be tarpon. We'll have to see.
Wow. I like fishing. I enjoy fishing and hunting very much.
Nice.
Yes.
It's one. What else do I do? I'm writing a novel right now, but other than that, I go fishing. So.
Wow. Do you live down there?
Yeah. No, I live up in Massachusetts.
Oh, gotcha. Oh, the Keys are beautiful. Oh, yeah. Gosh. Laid back, relaxing, great place.
Agreed. So it was wonderful having you on the Fireside Chat. Delighted to help you along the way if we can ever, and look forward to seeing you at the next meetings. And
thank you
great work, great article in wound repair and regeneration.
We got more work to do scientifically, really proving it out. And this has been a great honor for me to be here. I love attending the Wound Healing Society lectures at the SAWC. That's a big thing that I go for. And I'm a member, so it's wonderful. So I greatly thank you for the opportunity.